Okay, I think we can formally start now. Okay, so what? Okay, yeah. So basically, me and Munaza, we are working in the NHS, and we took our exam as overseas candidates as well. So because now we are working in the NHS, so we have understood the system a bit better. So I can totally appreciate that the candidates who are working overseas and they are taking this exam, the only problem with them is to understand the system, because obviously you've got lots of knowledge, and especially when you have taken such a difficult exam like part 2, then you have got lots of knowledge, but it's just how to convey this knowledge to the patient and the examiner, and also to understand the system. So in today's session, we will try to discuss if you have any queries related to that as well, but we will also discuss what is required from you in this exam, and also the domains, and briefly about the modules as well. Okay, and I think one of the candidates, Samreen, probably Samreen or Sumera. Yeah, Sumera. She requested to present a case. So if she's here, then she can present the case. Okay. Okay, let's move on to my presentation. Okay, so can someone tell me that obviously most of the time in the exam there are recalls, but there are at least 4 or 5 new stations. So what do you think that, because most of the candidates do the recalls again and again, and you will do obviously the scenarios which are there in the books as well. But what would you do if you see an unseen scenario? Who would like to say something about this? February candidates? Yeah, it would be really good if you guys talk, yeah, instead of writing. Yeah, that would be easier. Thank you.
Can I try?
Ma'am,
Yeah, of course. Yeah.
as usual, we'll introduce ourselves to the patient and ask the concern of the patient. I mean, as usual, ma'am, confirming the name and age.
Sure, that's fine.
And
But the thing is that, for example, you are obviously this is now a new system. You will not be standing outside the cubicle, but you will be looking at your screen on your computers, isn't it? Everybody is taking an online exam now. Yeah. Okay. So
yes, ma'am.
yeah. So for example, you see a scenario which you haven't seen before. Then what would you do?
So need to identify the module, and we are having the basic template of each module. So we can follow according to that template. For example, if the patient is, the case is regarding the maternal medicine module, and we don't know the case, but we can ask about the disease and how long she is having, and when it was diagnosed, what was the events has been diagnosed, and how she's following, and how's the control, and what medication she is taking. So according to the module, we can, I think, can identify and can have the implications of the basic module.
Yeah, that's a very good answer. Thank you so much for sharing that, Noreen. And yeah, so yeah,
We can go with the flow of role player. Like we can ask her precisely what are your concerns, anything else you want to ask me, and do you have any question for me? So when we have no idea how to move about, we can go with the flow of role player. Like she will tell us.
Sure, yeah, exactly. When you ask an open question, things will be much easier for you rather than, asking what you are thinking. Let them speak. For example, it's a very good way when you start your scenario. You don't know much about that. you don't know much about the patient's concerns and how to go along with that. So exactly, what you can do is to introduce yourself, and then you can ask her, how may I help you? Or you may ask her, why, I mean, very nicely and politely, that what has brought her to the clinic today. Yeah, exactly. Yeah. Okay, so
Right.
yeah, it's
I
really good.
would,
Yeah.
I would like to share one important human factor in this case, that when we see unseen scenarios.
Munaza, would you like to introduce yourself? Munaza is one of your mentors. Yeah, he's my friend.
Hi,
Yeah.
I'm also working in NHS with Amara, and uh, looking at that, how much the overseas has to do, we both committed to help out all the candidates. And the basis of the success of your MRCOG is based on how you approach to MRCOG. The thing is that mostly it is your effort, but the people who guide you also matter in that case. Therefore, after working for 3 years, we do understand that it is an opportunity now to let all overseas or IMGs to plan in a better way. Thing is that unseen scenario is something that is a sudden nerve wrack to someone. Therefore, it is important just to understand that, yes, it is an unseen, and in 2 minutes, you are not going to lose yourself knowing that it is something that is out of the scope that has come. When you keep your nerves strong outside of the station, it is very easy for you. And even if you don't know anything, just go into the cube and start with open questions. That is the key to access such cases in which you don't know much. Okay. I will hand over to Amara again.
Okay, sure. Yeah, exactly. Yeah, so I totally agree, and it's really good to see that the candidates have.
Yes, Amara, please.
Yeah. So candidates have got a basic understanding that if you make a template of each module, that it would be very easy for you. Okay. But what we most of the people know it now, that each module has got some requirements. So let's dig a little deeper into that. Okay, so obviously, as we discussed, for each module you will identify the module. If you have identified the module and you do the basic things that is required of that module, you will pass the station. Okay, even if you don't remember each and every drug, because then you will be covering your basics. Okay, so it's a very good idea to make templates for each module. For example, for the antenatal care module, it's very important to identify the risk factors. Read the scenario carefully and identify all the risk factors. And it's very common. We'll see a few scenarios, and then we'll see that it's very common to miss a very big thing that is there. And it's just like focusing on a fly which is sitting on an elephant. It's just like that. So sometimes it happens. So for example, for antenatal care module, basically women who have risk factors.
Cannot hear anything.
You can't hear? Just a second. Just a second.
Yes, no sounds.
Okay, wait a second, sorry.
I'm trying to get hold of Amara because she was about to present the slides. And let me contact her, okay?
Hello?
So guys, there is some technical issues, but Amara will be back soon to present her presentation. Don't worry.
Okay, thank you so much.
Okay, can you guys hear me now?
Yes, Humara.
Yes.
Okay, perfect. Thank you very much. Okay, yeah. So I was telling you that, as you guys said, that you know, for each module there is a template, and if we follow the templates, then at least 60% of the problem is solved, I would say. Then it depends upon you how you take that scenario. Obviously, there are other things that we will discuss. For example, in case of an antenatal, in case of the antenatal care module, women generally have all their antenatal care with the midwives. Am I still audible?
Yes,
You are.
Yes.
Okay, perfect. Thank you. Right. So women have their antenatal care throughout their pregnancy with midwives and GPs, and they do not come to the obstetricians unless they have got risk factors. Okay. So women will only come to you if they have problems. So if they are referred to the clinic, there is a reason. So it may be either a raised BMI, previous history of preeclampsia, diabetes in previous pregnancy, anything like that, history of a small baby previously, and you name it, lots and lots of scenarios. So in that case, obviously you will, with the antenatal care module, you will look at the risk factors, you will do the VT risk assessment in every woman, screen every woman for domestic violence very sensitively, and then obviously if you make a plan for each of the risk factors, then it's sorted. Okay, and you can take her throughout the pregnancy, to delivery, to postnatal, to contraception, and then refer her back to the community. So that's basically how in this module you can handle things. Similarly, as we discussed, I think somebody gave an example of the maternal medicine module. We know that only two types of scenarios can come, like pre-pregnancy or early pregnancy. Okay, in pre-pregnancy it will be actually easier, but then in early pregnancy, if she's pregnant already, same things, but the only difference is that she's pregnant. So you will tell her about the shared care, MDT involvement, and breast is as above we discussed, VT, DVT, domestic violence, and any other risk factors. So yeah, so you will go by that again. Likewise, in general gynae module, you start with history of present illness. Since our days in the medical school, we know that with every problem, we go by the history of present illness. Okay, so you will go similarly. And another thing that's very important in this module is quality of life. If it's affecting her quality of life, that's why she's here. Otherwise, her GP might have managed her. Same as I told you for the antenatal care. People do not come to the hospitals for trivial issues. They only come when the primary care is not able to manage them anymore. And also again, VT risk assessment is very important throughout all the scenarios in this exam, and domestic violence, and 3 options for every woman: conservative or like lifestyle measures or stuff like that, and then medical management, and then surgical as appropriate. And sometimes it happens that the woman is asking for something which you don't think is a recommended option, and in that case obviously you can tell them that yes, this is an option, but in my opinion this is not the recommended option in your particular situation. So this is how you can deal with them. And same for urogyne, same as above as we have discussed. But we have to be mindful of the fact that we have to think about all the 3 compartments: bladder, vagina, and rectum. Okay, and I have made a mnemonic in my group, 5 B's for urogyne: bladder, bowel, bulge, her sexual life, boyfriend, and there was another one. I don't exactly remember what was that, but I told them. So this is how you can simplify things for yourself. Okay, so for every module, make your 1 or 2 line keys just like that, or templates. Okay. Right. Okay, so what do you understand by the domains? For example, let's talk about the information gathering domain. Would anyone like to comment on that? What do you understand by the information gathering domain?
How we collect information from the patient that relevant to her concerns and her diagnosis. So we have to tackle all important information from her so that we reach the diagnosis in the end.
Exactly, yeah. Can you elaborate a little further that what do you mean by information? Like you said very well, but I want you to tell a little bit more about this.
It is about
Starting by her concern at first, like what is her complaint, the main complaint. Now we have to ask her more history details for this present, when it happened, and is it with associated any factors or symptoms that she has, aggravating factors. Did she have any medicine for that or not? And other than we will, if she's pregnant, then we have to ask her how she cope with this pregnancy. Did she take, she did any dated scans, anomaly screening for the Down syndrome? And if she's like in late pregnancy, so how her baby kicks, how is the all investigations, if she has any other problems with that. Then her social life, how's what she is doing, and if this her work is hazardous for her health or pregnancy. How are her sexual life and screening of the cervix. Also, how's her family history, if there is for VTE or a cancer, if she gynae case, and if a past medical history, past surgical history that make her high risk or not. And her allergy, her drugs, if she's taking any medications now. So we have to go through it, but like in organized manner, then to take an all high risk points, we have to make it clear.
Yeah, yeah, exactly. So when you will do that, that will come in applied clinical knowledge. So you have explained it quite well, but I would like to add something here, that I totally understand that you meant to say that it's history, it's examination, it's investigation. So that is all information gathering, yeah? It's all related to her disease. But what is her basic understanding of her problem? Okay, so that is also information gathering, because this will guide you how you will take the scenario. For example, if a lady, if she has a cesarean section previously due to placental abruption, and she was extremely traumatized from that experience, it's a recall scenario. I'm 100% sure that you guys know that. So she wants a home birth. Okay, so even if you take the history, all the history of which is relevant, you will talk about previous cesarean, you will talk about abruption, but if you do not address the fact that she wants a home birth and what are her concerns to be in the hospital, so then obviously you will not be able to, address uh, her concern, because you haven't gained proper information. So basically these domains are interlinked. You cannot separate information gathering from patient safety and patient safety from applied clinical knowledge. And obviously communication with patient encompasses everything. Yeah, do you guys agree with that?
Yeah, absolutely. Sometimes in the patient safety, we have to ask her allergy from the history.
Exactly.
Sometimes also her blood group of RNA reservations, if she's Jehovah Witness. So this is safety also if she's high risk for like a placenta previa or
Yeah,
something for bleeding.
yeah,
So yeah, safety can enter in the information gathering, yes.
yeah, exactly. So these, basically these domains are interlinked. Yeah.
I would like to say one more thing,
Mm-hmm.
that in addition to the templates that we have for information gathering, it should be different from the medical students. So most of us do prepare those according to the, because the medical student take the very explicit history. We should take that. But what makes you different is that you ask two more important things. That is the concerns of the patient and expectation of the patient. That will differentiate a good candidate from an average candidate. So in each scenario, try to make sure that you touch those 2 points where you are getting the information from the patients. Concerns and expectations of the patient.
Yeah, exactly. And this is called the ICE model. I'm sure you guys are aware of that. And I think in one of the books it's mentioned that break the ice. And breaking the ice is not just building the rapport, okay? It's to know what is her idea and her background knowledge of her condition, and what does she think about herself, and what are her concerns are not complaints. So there is a difference between concerns and complaints. She is here, for example, with abdominal pain. That's not a concern. she is concerned that she might lose her tube, because if it's an ectopic pregnancy, she doesn't have a tube already or something like that. So that's the concern. Okay, so it's important to make sure that we address all the concerns. Yeah, and 10 minutes is a very short time. I totally agree with that. And but with practice, you will learn. Yeah. Okay, so I think we have discussed this bit as well. So just remember that there won't be anything out of this world. You have been studying for such a long time, and then you did your MRCOG. You've got lots and lots of knowledge. So it's just that we are very focused on the recalls and some scenarios that which are common, and they do come in exam repeatedly. But as we said, identify the module and see what type of task is that. Is it a structured discussion in which you will be using a very professional language, and like, you know, if for MDT members, you can name them. Okay, and obviously in simulated patient task, it even doesn't matter if you don't tell the patient who is a hematologist, or I mean, if you can tell in simple words, it would be good, because obviously while communicating with the patient, we don't want to flunk in the applied clinical knowledge domain. Okay, so simplify everything, but if you identify that, your life will be easier. And then back to the basics, as we discussed: history, examination, investigations, and then try to decode. So we'll see a few scenarios and we'll try to decode. Okay. Okay, let's decode this scenario. Yeah. If you guys can see my screen, there is a scenario, and one of you can volunteer to decode. You guys can see my screen, right?
No, I cannot see the screen, unfortunately.
You can't. You can't see my screen. Okay.
Yes. At the beginning of the session, before you log out, we could see it.
I think because I am the host, and when some people want to join, then okay. Just a second, sorry. Can you see now?
No.
Still not. Okay. I don't know what's the problem. You can't see my screen now?
No.
No or yes?
No.
No.
Okay.
Cannot see.
Okay, maybe I have to reload again. That's not good. I'll try again. Sorry. You can you see my screen now, or you can't see it?
It's not coming. I can share in the meantime. And just
do you have an option? Yeah, if you can. Thank you very much. That would be good. Okay, so Munaza's screen is visible?
Yes. And we are able to see D. A letter D is visible, ma'am.
Munaza, if we can go to slide 5, please. See if they can see it.
We are on slide 5.
Can you guys see the screen?
Yes.
Okay, perfect. Yeah, okay. So what do you think? One of you can volunteer. What do you think about this scenario? How will you decode this scenario? First of all, yeah, you try it and then we'll discuss.
But take 2 minutes, because this is something that practice, exam practice, it will help you in summarizing in 2 minutes.
Yeah. I think we can discuss here.
I can try.
Yeah, sure.
Okay. I'm Dr. Amal, one of the doctors in Gynae Clinic today. May I confirm name and age?
No, sorry.
Ah.
I just want you to tell how you will deal with this scenario, not present. Yeah.
Okay, it's okay.
So what are the features that you can see here?
Yeah, she is a Somalian and she is young. She is 17 years old and she has an acute episode of lower abdominal pain and very anxious and vomiting. I would like to see if she's stable now, what pain medication she took or not, and if we can take a history from her now. Then after if she is stable, then we have to know when it started and what happened before she got this one. If she had any operation like female genital mutilation, this is as her Somalian, maybe she got something. So we will ask from her like what is started, how started this one, and if there is any associated factors than this, her other than parts of the history, if she what her concern also, we have to address it in the beginning. Maybe she will tell us from the beginning, and we have to assure her that our confidentiality, what will speak, it will be between us, so just she can tell us if there is anything. And we have to exclude also domestic violence or child abuse. And if we have to ask her if she is active socially or sexually active or not, and with whom she is living, is like safe place or not. And if like it is something, we have to involve the social worker or safeguardian, or police if it is acute FMG. And other than this, if nothing, so we have to complete our information gathering, like all her allergy from medicines, what's medications, if this is after gastroenteritis maybe only, and if there is any like before any family member have the same symptoms or not, if there is a fever or not, and examinations, vital signs, and abdominal examination. If there is any tenderness, maybe it is also an appendicitis, so we have to exclude it. If there is any scans done, we have to examine from down below and her abdomen. Investigations, we will run full blood count and CRP and urine electrolytes as she is vomiting, and if she's dehydrated, so we have to correct it. Yeah.
Okay, very well done. Thank you very much. Can someone add what else do we need to think about?
Is there any, whether she is pregnant?
OPT should
We should do
pregnancy.
Confirm?
Before everything.
I lost connection, ma'am. That's why I'm asking. And whether she is having a urinary retention. These two things we have to examine and
I think miscarriage
record accordingly. And whether she is having any ectopic. We have to do a scan.
Before everything, I think we should ask that whether she required any interpreter. And
sure, yeah, that's fine. Yeah. Okay, yeah. So I mean, basically the point here is that it's the word Somalian that takes you to FGM, yeah, and you might be deviated from what the actual thing is for which she's here. Okay, so when you are in the gynae ward, generally you see the patients who present in emergency, okay, and they are referred through A&E. I'm just telling you the background. It's just to understand how the system works, but otherwise, I mean, you will do whatever you are required to do. So yes, the differential diagnosis will be the same. Ectopic pregnancy, ovarian torsion, very important differential diagnosis in case of young or whoever women presenting in the gynae with acute abdominal pain. For gynecological causes, obviously, if she's pregnant, ectopic pregnancy. If she is not pregnant, it could be an ovarian accident, cyst accident. It could be a hemorrhagic cyst. It could be a ruptured cyst. It could be ovarian torsion. Okay, so we have to think from that point of view. whether she has got UTI, whether she has got gastroenteritis, as you said. So all the symptoms and everything. And obviously, FGM is a part of that, but it's not that we will be focusing our discussion just on FGM. Yeah. So if we try to decode, as you said, that she is a young girl, she is Somalian, so we will ask for interpreter. So these are the things that will come in your mind. She has presented with abdominal pain. So, keeping in mind all the different diagnoses, you will approach her. She's anxious, she's vomiting, as you said, if she's vomiting, she might be dehydrated, then we will give her IV fluids and things like that. So yes, obviously when you do the scenario, it will be an interaction with the patient, so there will be other things that will come up. But when you look at the scenario, highlight all the points. Do not just fix your mind on one of the things. Okay, let's move on to the next one. Okay, read this scenario. Munaza, I think my screen is not visible. Can you move on to the next one? I think you are on that. Slide number 6.
It's slide number 6 now.
Yeah, okay. Okay, guys, look at this scenario, and one of you can try decoding this one. I think we can go ahead with that. Who would like to decode this one?
Ma'am, shall I, ma'am?
Yeah.
She is 22 weeks pregnant in her second pregnancy. The first one being a cesarean section. We do not know the indication, and it was complicated by PPH. Whether there was a history of any antepartum hemorrhage, we should go. We should know by history taking, and it was a major PPH. The anomaly scan at 20 weeks shows a submucosal fibroid, and we should know what is the position of the placenta.
Yeah.
Placenta localization also we should ask, ma'am. And she is having low BMI. Okay, ma'am. So she is more prone for development of small for gestational age, and we should ask whether she is on aspirin.
Okay, but if she has a low BMI, then I don't think this is an indication for giving aspirin. Yeah, what do other people think?
Whether there was a previous history of APH, ma'am. If it is there, we can.
Yeah, so we will see what she tells in the history. But looking at this scenario, there are certain risk factors that we can see, and there are other things in this scenario as well. Anyone else would like to comment on that?
She has got a submucosal fibroid.
Fibroid, so
the bigger one. 5
like
centimeter.
miscarriage or preterm birth or low birth weight baby, because there will be less inside the womb for the baby to grow. So EPROM, preterm labor, and NICU admission for the baby. Because
risk factors in this patient would be submucosal fibroid, her BMI being 18, previous cesarean, and a past history of PPH.
Okay, there is something else in the scenario.
Risk of placenta previa and accreta can be there because she has previous surgery and also high risk for PPH.
The cause of cesarean section last time. What was the cause of cesarean section?
Anything else? There is something else. Read the scenario again.
Her fertility wishes, and we should ask
that scan shows fibroid, but at 3 weeks has normal. They didn't mention about the fibroid.
Okay.
She is actually waiting to see the consultant.
Excellent.
Where the consultant is
That's the point. Yeah. Consultant is not there. Yeah. So what
not there. So we need to first apologize, and whether she would like to continue or she want to reschedule the appointment, we should take her wishes.
Yeah, exactly. Yeah. Yeah. So this is how you decode here, because you cannot ignore even a single thing which is mentioned. They haven't given so much information for no reason. Okay. So yes, she's 22 weeks pregnant. She's referred by her midwife. I mean, we have already discussed that all the women will have community care and they will be referred by the midwife or the GP. So she's in the antenatal clinic now. She's waiting to see the consultant. The consultant is not there. So you will do what I think you are Vishnu Priya. Yeah. So what she has mentioned.
Yes.
Okay.
Yes.
Yeah. Okay. So yeah, obviously you will apologize and you will ask her whether she wants to have a chat with you or she would like to come for the consultant again, because this is just an antenatal visit. So she would definitely say that yes, I would like to continue. But then before she leaves, you can offer her that whether she would like to come again for the consultant or whatever. Yeah. So yes. So we know that the baby was delivered by cesarean section. So we will go through everything. We will go through her history. We will see her notes, and we will do the routine things. We will ask her wishes about delivery this time. And since she has a PPH of 1.7 liters. Another thing why I mentioned BMI is that not because of her risk factor for SGA. That might be a risk factor for SGA as well. She had a PPH of 1.7 liters, and if her BMI is on the lower side, it will be an earlier call for major obstetric hemorrhage protocol, isn't it? Because she has less reserves, she will not be able to cope with blood loss, that much blood loss. Like even if 1,000 liters for a normal weight lady, she might show signs of decompensation earlier. So that's important. Okay. Yeah, so that's why it's important. And obviously when she has got a submucosal fibroid, at 20-week scan it was not seen, but it doesn't matter because it was seen at 13-week scan. Okay, and at 20-week scan, because focus is baby, so probably that was not seen. But anyways, it's a diagnosed fibroid and they have mentioned the dimensions very clearly. So you will discuss everything that you have mentioned, that APH, PPH, and you know, whatever is expected with when women have fibroids. So if we have time, we can do this scenario later on. Okay. Munaza, can we move on to the next slide? And we'll go through the slides quickly and then we'll do a scenario. 7. Can you guys see slide number 7?
Yeah, it is.
Okay. Yeah. Okay. So I wanted to say a few words about the smart use of pills, because when we started our preparation, like when I started, me and my study partner were totally naive about this part 3, and we didn't know anything, and you know, we just thought, let's start reading the pills. Do you think it's a good idea to start reading the pills?
Yes.
Okay. Yeah, but if you read the pills, what difference will it make?
To make yourself familiar with the lay language and how to explain it simply to the patients.
Yeah. Yeah.
Communication with the patient will be in a better and concise.
Yeah, that's fine. Yeah, that's fine. But the thing is that it's very important to make smart use of the pills. It's not just you just go through the pills and you will not remember anything. Yeah. So when you do scenarios, you try to practice that language. That's one thing. Everybody knows that. But what I want to focus is that when you look at the pill, for example, there is a pill for ectopic pregnancy. Yeah. So when you go through that pill, I'm sorry I cannot share my screen. Otherwise, I would have shown you that pill. I mean, everybody's familiar with that. So it covers pregnancy of unknown location. Okay. It covers ectopic pregnancy with a HCG, which is in which situation we can do the expected management, we can do medical management and surgical management. So this is how you can make different scenarios from a patient information leaflet, and you can think in your mind that, look, from this patient information leaflet, this, and this, three things can come, isn't it? So reading the pills blindly will not be useful. So look at the leaflet and create scenarios on your own. And for example, for VBAC, many women here they request cesarean section, like a repeat cesarean section. Then what we do is to go through the pros and cons of the VBAC and the elective cesarean section with them, and then we refer them to a special clinic. You guys also know that's called either birth choices clinic or mode of birth clinic, and then they make a decision. So this is how you can make your scenarios while reading the pill.
Another important thing is that when we read patient information leaflet and the same scenario come in the exam, it does not mean that we have to read all the patient information leaflet to the examiner or to the lay examiner or to the patient itself. You know, the main concept of PIL is that how much of information you have to give to the patient. So these PILs are very nice in this way, but if like in ectopic pregnancy or miscarriage patient information leaflet, they describe all the three management. It does not mean that you start from the expectant management and then medical management and then surgical management. This is how an average and an outstanding candidate differentiate. For example, they will clarify all the information to you that a patient come with heavy bleeding. And when patient is coming with heavy bleeding, you have to tell all the options, but you have to prioritize which option you are going to give first. So you will explain expectant management, but you will say that you are bleeding a lot, the blood pressure is lowering down. We think at this moment, surgical option is the best moment. However, there are other options that are this. So it should not be a blind approach to memorize PIL and vomiting out all the PIL in front of the examiner. It should be that you understand the scenario that is given to you, and then you are recognizing the problem, and based on that, how to switch over the management plan, how to switch over the information gathering. This is your main aim to do at that time when you are standing outside of the station, and then when you are giving these information accordingly, the examiner will definitely click you the best candidate at that time.
Yeah, thank you very much. That was very useful. Yeah, and when reading the information leaflet, you can also mark some points, like this will be the point in the information gathering. This comes in communication with the patient. This comes in communication with colleagues. This is applied clinical knowledge, and these are the patient safety points. So you can always, rather you should always think in terms of the domains, not just looking at the scenario, because these are the things you will be tested on. Okay, so that was basically it, and then we can come to the scenario. I think Sumaira wanted to do a scenario.
Yes, doctor.
Okay, right. Munaza, can you bring up the scenario? Okay, so before bringing up the scenario, each and every one of you, what we will do is you guys can, if you guys type messages, there will be hundreds of messages, we won't be able to read that. You guys can make small keys, but now you should practice. Maybe you can make small keys on your phone and send them in the Telegram group. Yes, that's a better idea rather than having messages here. And each and every one of you can do that. And once she presents, then I'll take feedback from you guys first, and then we will give feedback. Okay? So be prepared for the giving her feedback.
So, Sumaira, I will be putting this scenario for complete 2 minutes so that you can organize your agenda, okay?
Yes, sure.
Manaza, you want to be the role player or you want me to be the role player?
You can be the role player and I will mark accordingly.
Okay.
Can you see the scenario?
One of our group members, she mentioned a few minutes back that she's not able to be in. Let me try to get her in. I'll mute myself.
Okay. Until that time, I will put the scenario and I will put the clock on as well, okay? Your time is up now. We can start the scenario.
Okay. Hi, I'm Dr. Sumaira, one of the doctor in the clinic today. May I confirm your name and age, please?
Yeah, I'm Sarah Smith and I'm 25.
How would you like to be addressed?
Sarah is fine.
Okay. Sarah, I can see that your midwife has referred you over here to discuss about your plan of pregnancy. Am I right?
Yeah.
Okay. Any other concerns you have from today's visit?
No, I just wanted to know how will I do I need to come to the hospital, and yeah, it's very difficult for me because I'm wheelchair bound, as you can see. Yeah.
Yeah, I can see that you are a wheelchair user and things must be very difficult for you. So how you are coping with these things with along with the pregnancy?
I mean, it's fine. This was an unplanned pregnancy, but I was happy to continue. So it's okay now. Yeah, I'm managing.
I'm glad to know that you are doing all, but you have enough support for this.
Others, you mean
You have
you mean
help available along with this wheelchair use.
yeah, I live with my mom, so she's aged, but she tries to manage. Yeah.
Okay. Okay, Sarah, would it be okay that if I will ask a couple of questions regarding your general health and then I will discuss the plan of pregnancy with you?
Yeah, exactly.
Okay. So, can you tell me how long you are on a wheelchair and can you tell me in detail about your condition?
So actually, I don't know it's you know or not. I had spina bifida when I was born, so I had many surgeries for that, and I have been like that since my childhood. Yeah.
All right. And when was the last operation?
Sorry?
When was the last operation done?
Oh, I don't remember. It was ages ago when I was very young, a baby.
All
Yeah.
right. So, are you able to control your water bag?
Yeah, so I have got a catheter.
Okay. And any irritation in your skin and the down area?
No, it's fine.
Are you able to control your bowel movements?
Yeah, it's fine.
Okay. Can you tell me about your pregnancy, Sarah? How's pregnancy so far?
Yeah, it's going good. As far as I know, my
Mm-hmm.
scan was normal, which I had
Mm-hmm.
just a few days back.
Mm-hmm.
And the doctor, my GP told me that the blood tests are also okay. Yeah.
Right. Is this a planned pregnancy?
No, it's unplanned.
Okay. So were you using any contraception?
Not really.
Okay. So let me tell you, Sarah, that after this pregnancy, I will book you for a contraception clinic because it would be difficult when you will land up in an unplanned pregnancy.
Mm-hmm.
So you want to continue this pregnancy?
Yeah, I'm very happy. Yeah.
Okay. Okay. So um, are you using folic acid?
Yeah, yeah, I am.
And how much dose you are using?
I'm using a prescription which my GP wrote for me. So it
Mhm.
was not like an over the counter, but
Yeah.
I think I started when I was
Yeah.
just a few weeks back, maybe a
Yeah.
month back. Yeah.
Yeah, actually, in your case, due to spina bifida, we are prescribing little higher dose that is not available over counter. It's around 5
Mm-hmm.
milligram. So that's really fine.
Okay.
Okay, can you tell me, is this your first pregnancy?
Yes.
All right. So, how's your period? When was your last period?
I don't remember. My periods are a bit irregular, so I don't know. But the scan says that it's a 13 weeks baby. I saw my baby's heartbeat here. It was nice to see.
Yeah. Okay, good to hear this. So, are you up to date with your cervical screening?
Cervical screening. Yeah, I had an invitation, but then I thought
Hmm.
then I was pregnant, so I couldn't go. Yeah.
Okay, it's okay after pregnancy, as it's really important to follow up with the cervical screening. All right, so I
Okay.
will check and book your next appointment with the cervical screening after delivery.
Okay. Yeah.
Okay, so any apart from this condition, any other health condition are you following GP?
No, no. These
Are
are a
you
few.
allergic to any?
Yeah.
Okay, are you allergic to any medicine or substance?
No.
Any medicines you are using on daily basis apart from folic acid?
No.
Okay. Um, um, any health concerns in your family?
Health concerns. I mean, everyone is okay. My mom is fine. Yeah.
All right. And do you smoke?
No, I don't.
Drink alcohol?
No.
Using any recreational drug?
No.
Okay. And what do you do for a living, Sarah?
I don't do anything at the moment, but I plan to
Right.
after I have my baby. Yeah.
So who's supporting you financially, Sarah?
I live with my mom. Yeah, she works.
All right. Uh, Thank you for sharing the information. One more I want to ask that have you ever been low down or depressed in the last 4 weeks?
No, it's okay. Yeah, I mean, when I came to know that I'm pregnant, it was a bit uh, of a shock for me, but it's okay. I
Yeah.
feel happy now. Yeah.
Okay. Anything else you want to add, Sarah?
No, no,
Okay.
that's it. Yeah.
Thank you for sharing the information, Sarah. I would like to examine you after discussion the plan of the pregnancy with you. My
Mm-hmm.
nurse will check your blood pressure pulse, and I want to feel your tummy. And now let's move on to your plan of pregnancy. I have your results. Um, Now let's move on to the plan of the pregnancy. As you know that you are pregnant around 13 weeks, and the scan of the baby is normal.
Mm-hmm.
As you are having a spina bifida, so your pregnancy would be a high risk pregnancy, Sarah. So we would suggest you to book in a consultant-led unit, and your care would be shared in a group of doctors, including me, my consultant, and a physiotherapist, your spina bifida doctors, surgery doctors, along with the specialist nurse, and also home visits by the community midwife. As I can see that it must be difficult for you to come to us on every visit, so the care would be shared between us.
Okay, that's fine. Yeah.
Okay, then regarding pregnancy, as you already now 13 weeks, so uh, because of spina bifida, there are some risks for you and there are some risks for your baby. So we have to take care of those risks during the care. Some risk for you that as we can see that your height and weight ratio called BMI is normally we are taking up till 25, but in your case it's around 35, so it's little higher. That can lead to the formation of clots formation in your body. For avoiding that, we need to give you some blood thinning injection and a tablet. We need to start from now.
Which tablet is that?
Aspirin, after ruling out some blood test. Okay, and then because of this condition there are some risk for urine infection also. So
Okay.
for that, every visit we will check your urine test, urine for protein and infection,
Okay.
for ruling out the infections. And regarding your baby, there is a risk that this condition can transfer to the baby, but there is very less risk for that. So we will arrange detailed scan of your baby around 5 months, Sarah. Okay, don't worry, we are here to support you in this pregnancy. We will do as much as possible. And regarding, yes, there are some risk of early delivery of the baby also. We are calling preterm delivery. And low weight also risk is there for that. After around 7 months, we will follow you via uh, a 4 weekly scan to see the weight of the baby. Am I clear so far, Sarah?
Yeah, that's fine. But I'm
Okay.
feeling a bit anxious now because you said that I have got risk of having a small baby and early delivery. Okay.
Actually,
Yeah.
I can understand, Sarah. Actually, my job is to just make you aware of each and everything.
Okay.
But I can see that your condition is difficult. So what I can do now, I will arrange some counselors also, and also some support groups who are share their experience. The people who get pregnant in same in your condition share their experience. That must be helpful for you. What do you think, Sarah?
Yeah, I think it would be good because I haven't heard of any of my friends where I go, uh,
Mhm.
the support.
Mhm.
I'm in touch with a support center, so there are a few girls,
Mhm.
but none of the women has ever been pregnant. So yeah, that would be good.
No worries, I will share the contact detail with also. And also, I know I'm giving lots of information. So what I'm gonna do, I'm providing some written information leaflet so that you can just sit, relax in your home and just take a second look on that. And if anywhere you want to ask again, we can arrange second appointment over here and you can ask. Regarding the delivery, your delivery would be, we will plan for a vaginal birth unless there is some other indication for that. And regarding the pain relieving at the time of the delivery, we will book your appointment with the anesthetist doctor in the last 3 months of the pregnancy. He will discuss the options of pain relieving during delivery. And after birth, you can feed your baby as a normal mom. And yes, in your case, we can
Time
do
up.
some arrangement.
Okay.
Time up.
Yeah, that's fine. But Samara, you can continue.
Okay. After birth, we can we after birth you can have options of some low baby changing tables and wheelchair friendly prams that can help you to take care of your baby also. And whatever
Okay.
help you require, we are here to help you. And as you said, your mom is also here.
Hmm.
So, and one more thing that very important thing after delivery, I will book your appointment for contraception clinic so that you cannot land up any unplanned pregnancy.
Okay. Yeah, that would be good. Yeah. Okay. Yeah. Thank you very
Okay,
much. Yeah.
thank you. So I will just tell my nurse to discuss take care of the catheter with you and book the next appointment with you. Okay,
Okay. Yeah, that's
thank
fine.
you.
Yeah. Thank you very
Thank
much.
you.
Yeah.
Thank you.
Thanks.
Anything you would want to add, anything
Uh,
important, just to remember.
Manaza, just a second. Before that, we'll ask Sumera about her reflection. Yeah, sorry.
I don't know. I think this scenario I read before, but long time back, so things must be here and there going in my mind.
Mm-hmm.
But yes, it's not perfect. Well, too many things missing, which just coming in my mind because of a lack of time also.
Mm-hmm. Okay. No, I think you did
Regarding
well, but yeah. So, do you think that can you think in terms of the domains? Just a very quick reflection in terms of domains.
yeah, Regarding information gathering, I think I forget about the blood group and allergy.
I think you asked
Just
about allergies. Maybe I
I
might
talk
be
about
wrong. Okay.
yeah.
Okay.
Yeah, I think I should, but blood group, I forget it's really important in antenatal cases.
Yeah.
And then regarding in the applied knowledge, I think a GP write back or midwife letters write back there. I didn't do that.
That's a safety point and communication with colleagues as well. That's fine. Yeah, exactly. Okay.
I miss it.
Okay.
And also one more thing I can add that we should refer to the Spina Bifida follow-up doctor.
Yeah, but you mentioned
Just
the
for that.
MDT, so I mean it covers it.
Yeah, I said
Yeah.
that. Yeah, okay.
Okay, that's fine. Thank you. Okay, who would like to give feedback? Ideally, the feedback should be domain-wise, but let's take a global feedback. Maybe 2 candidates give global feedback, and then we'll go to the domains and we'll discuss a little bit because I want one more scenario to be done if possible.
Can I share Dr. Amara?
Yeah.
So I think she, well done. She covered most of the point.
Yeah.
But yeah, she did not. I will go globally.
Yes,
Yeah.
that's fine.
And she did not ask about the partner. If this is a stable relationship or just like, yeah. And is yeah, she will support her or not. And regarding the support, did she know that there is some like charities can support her? And occupational therapist, I think, should be earlier so they can assess the home and accessibility because she will be pregnant and maybe it will be heavier. And then they can give her advice regarding the BRAM and everything. And what else? Regarding the folic acid, she started late, and this puts her at risk, her baby, of having spina bifida or the spina bifida at 20 weeks scan. And what else? About her previous surgeries, we need to review her note to know if her pelvis is affected with any other surgeries. What the level of the spina bifida, because this maybe change our management as well. If it is low, it will be okay, but if it is higher, maybe autonomic dyslexia, I think. I think, yeah, we need to know the level of the surgeries and what surgery is done by review her notes, if any operation done on the pelvis. And I'm not sure if we need to see if the pelvis is adequate for delivery or not.
Yeah, yeah. Yeah, we can have a chat about that exactly in terms of mode of delivery later on. Okay, so I'll hand over to Munaza for the domains and tell you a little bit more about Spina Bifida. But my 2 comments that I was feeling good as a role player, that she was addressing my concerns. So, and she was empathetic. So in my group, most of the time people post scenarios alone, so which I actually don't like, to be very honest. But obviously everybody is busy and it's sometimes very difficult to get hold of other people. But it's very important to practice with your study buddy or anyone else, and even your sister, your friend. I have listened to scenarios when we were preparing for exams. People practiced with their daughters and mothers, so you know, anybody, and they could tell you how were they feeling. So that's really good. But anyways, I was feeling good as a role player. Okay, and you didn't focus much on her BMI. Her BMI was 35, and you mentioned about aspirin, which is good. There is a risk of gestational diabetes when the BMI is high, and also preeclampsia/PIH. So we have to make a plan from that point of view. Okay, so again, if we, Manaza, can we go back to the scenario, please? Okay.
And the risk of pretty risk assessment.
Yeah,
at
and
this moment.
and for the family history, you asked very generally that are there any health concerns. I would say that because I can tell you that the risk of VTE very high here, to be very honest. I have seen that personally now. Yeah, so you cannot miss that. So when we see people, women in the antenatal clinics, then there is a performer on the EPR, which is the electronic system on which we are documenting everything. So there is a performer, like a checklist or a form, and then we do the VT. We can do, I mean, I generally do formal VT risk assessment for most of the women. So family history of VT is specifically asked in the antenatal scenario, especially. You can ask in every scenario, any history, any family history of concern you would like to mention, and any history of clots in legs or lungs or brain in your family, specifically ask about that. So that's important because she has got a raised BMI. She is wheelchair bound, so she would score. Okay, yeah. So that was very important. And as you said, she's a vulnerable woman from my point of view. I think so, because she's wheelchair bound. She's got a medical problem, and she's pregnant. So we need to ask about the partner and a little bit more about partner support, or is that a stable relationship, or it was a one-off, and a little touch a little bit on domestic violence. Yeah. Okay. So I'll hand over to Manaza.
Oh, very nice presentation by Smera, well done. There are a bit of things because Amara was doing role player, so I was examiner and I was, just assessing the other soft skills as well, like how friendly you was, and how much you keep her involved in the conversation. So it seems that you know a lot about this scenario. Your approach was good, but there was just sudden opening that, okay, you are on wheelchair. It sounds, a layman examiner will point out that you are stigmatizing, and patient might, if I am someone, I will also feel the same way that, okay, you are saying me that I am wheelchair. Starting only 30 seconds, make it a bit friendly. Okay, how are you? You are pregnant. Is it a planned pregnancy? She will say unplanned. Oh, you want to continue? Yes. She told you that already that she want to continue. And have you started feeding? The scan is done. Are you happy? Where is your partner? Start a bit friendly and then start your checkbox. 1, 2, 3, 4. So layman will then say, fine, she is good. Fine. So start with this way. After, when a scenario is given and information is provided, you can reconfirm those, but I think during the conversation, you repeat on asking the information that was already given in the scenario. So this you can avoid. It will save your time to complete your scenario and reach to the postpartum care, which is and chances of recurrence and contraception at the end as well. So you can save your time by being very sensitive to your information gathering and not repeating the information that is already given. You can summarize those information in one sentence and reconfirm just to show the examiner that you read the scenario very carefully. So this is something that is very important. You asked about the dose of the folic acid. That means that you know that how much she should take. It was good. Important thing was that how long she has been with her spina bifida surgeons, and since she's long time on the wheelchair, it might affect her mental health status as well. So I think that that's important. Are you otherwise happy? Any changes in the mood? You can ask these things in a soft way so that patient can tell you, and the examiner know that you know that she's having disability and she is vulnerable on the basis of these things to the mental health issues as well, and you are ticking that box safely. When in regard to family history, yes, you ask about, there are two things that are going on. One is the clotting issue and one is the spina bifida. So spina bifida can also increases the chances of having babies with spina bifida is the partner is spina bifida. So if we can ask about this, that any problem, any spina bifida problem in the family or your partner, so that you are just ticking the box that you have asked this thing and you know that it's running in the family. This is about the information gathering. Rest of the information gathering is you full number on community